such as sepsis, acute heart failure, acute kidney injury, and cardiorenal syndrome in the emergency department. The current webinar will be recorded and later available online. It will take around 35 to 40 minutes, the presentation itself, and later we'll have a Q&A session. Please, could you write your questions in the text field on the right of the screen during or after the webinar, and we can address your questions after the webinar. And would be nice if you introduce yourself and also type the country of origin when you write your questions. Those of you who already joined us in the past two webinars know our presenter very well. I would like to introduce to you Professor Salvatore Di Somma from Rome, Italy. Professor is the expert in emergency medicine and biomarkers intended for use in the emergency department. He is a professor of medicine, chairman of Postgraduate School of Emergency Medicine, and director of educational programs at the University La Sapienza in Rome, Italy. Professor Di Somma is the author of more than 300 papers in the field of acute cardiac care, cardiology, and emergency medicine, and he is the vice president of the Great Network Association. This is a worldwide academic research organization that aims to develop research in the field of acute diseases. Professor is the expert in the biomarker research in acute care and emergency medicine. So with that, I would like to give the word over to Professor Di Somma.
Thank you. Thank you very much, Alessandra, for nice introductions. It's a privilege for me to be again here with the support of Sphingotec to present the third part of our webinars. This today will be a part devoted to address the importance of utilization of biomarkers thanks to point-of-care technology in the emergency room. And I will go during my 35-40 minutes presentation to present some data that are coming from the International Research Group of Network, that is a comprehensive of 78 countries worldwide that collect data in biomarkers and point-of-care technology. I think that what is important, first of all, I think this is I will present now. I don't know if there is any delay. Can you see my screen? Can you see my screen? Hello?
Yes, we see your screen, but somehow it's not clicking.
Sorry, can you hear me?
Yes. Yes, we can hear you. And we can see you.
Coming back and join again?
No, all good. All good. We can hear you and we can see the screen. Please go ahead.
Hello, can you hear me? Hello?
We can hear you.
Okay.
I apologize. Yeah, we can hear you, Professor. We can hear you and see you.
Okay, very good. Sorry, but I think was some delay in changing slides. Okay, this is my disclosure. Okay, now, first of all, make the definition of point-of-care testing. The point-of-care testing for laboratory medicine is something that is being located close to the patients, that does not require permanent dedicated space, and also what is important, that is a technology that can improve the time to intervention and the outcome for severely sick patients. That means that you are going to visit your patients and making the laboratory testing with the point of care, you make decisions. I'm going during my presentation to address these 3 points today. First of all, why do we need point of care in acute disease? I think this is the most important question, and it's coming from the fact that we know very well that there is a lot of emergency departments that are every day overcrowding. And this overcrowding system is due to the fact that there is a reduction in bed availability, so patients are waiting on the floor before admitting what is important this time to make critical decision, right? And of course, the more beds are available into the hospital, like here is a very clear showed in the white area, it means that you have no problem in terms of admission of the patients. While if you have a lot of beds already occupied in the hospital, there is a delay in admission of patients, and so the mortality is increased. And this is the reason why the job of emergency physician in this situation is even more important, because having less beds available for admission, the job of emergency physician to rule in the patients because of a disease will be very important in order to decrease mortality. And the other side, if you are able to immediately rule out the severity of the disease and diagnosis, you are going also to reduce overcrowding and reduce mortality. So when you have an overcrowded emergency department, the role of emergency physician is even more important in order to make rule out decisions. Now, this is a paper that we published some years ago into the GREAT network, showing that there is a timeline where you really want to make a decision in the emergency department in order to reduce patients' mortality and time to wait for to be admitted. And this time is within 4 hours. So it seems that from the literature, if you are able in 4 hours to make a decision, diagnosis, prognostic risk stratification, and therapeutical options, you are going to do a good job. If you are waiting more than 4 hours, this means that is going to be affected negatively the patient's outcome. And in this attempt to try to make a quite precise and fast decision in terms of diagnosis, definitely during the last years, the importance of laboratory medicine and biomarkers is becoming even more important. In fact, because the biomarkers are coming to be more effective because of increase in sensitivity and specificity, now at least 70% of our clinical decisions are also based on support of a biomarker. So the more the biomarkers are good in support of clinical decision, the better will be to making a reduction of time in definitely a diagnosis. So how can we really try to reduce overcrowding when we have a so small time to make a decision, 4 hours? Definitely, there are two tools, both on point of care. First of all, improving point of care imaging. We know very well that in all emergency room, we have a portable ultrasound device or laptop that are going to be linked with the clinical decision. But what we are addressing today is how point of care biomarkers are going also to help clinicians to make a diagnosis, a clinical final decision in 4 hours. That is the maximum time that is definitely considered a good option for patients' outcome. When we are going to compare, in fact, the time of results from good point of care technology with the laboratory, there is a clinical evidence that there are a lot of reductions in time to make appropriate options for the patient. So there is no doubt that there is a significant reduction of time for collecting to reporting using point of care technology in the emergency department compared to tube transported blood sample for central laboratory analysis. So from this paper, it is very clear that there is a lot of saving time that will be crucial for your patient. What is also important that, as we point out in this opinion paper of utilization of point of care system in the emergency department, there is also a lot of impact of emergency department overcrowding, and then to be much more fast and accurate in this final disposition. I think now is the most important part of our presentation today, which are the role of this new point of care technology, the new biomarkers to make a better decision in the emergency department for managing patients with acute disease. I'm going to describe briefly the technology. This is the Nexus IB10 technology. You see this a disc that is inserted in a very small portable device. What is really to be remarkable from this device that is portable, is small, and you can use whole blood. So this is really important. You are not going to make any centrifugation before using. And in this disc, you can have, you see, different holes for different biomarkers to be analyzed at the same time. So it is easy to put the blood into this disc, and contemporaneously, you can have different contemporary biomarkers assessment. Why you don't need to make a centrifugation before? Because the centrifugation system is going to be inserted into the disc. So you are going to separate blood cells, the plasma, and then within the system, you are going to save a lot of time. And generally, it takes 10 minutes from the moment you put the whole blood into this disc and insert it into the machine that you can receive the appropriate biomarkers you are looking for. So the technology is definitely very useful. How does it work? It works with a very recognized laboratory medicine system, robust sandwich immunoassay that is going to put together the analyte with the antibodies that are conjunction with the immunoassay format. And the way that this result is going to be detected is thanks to this light source. So thanks to this technology, in 10 minutes, you are going to have definitely the results of biomarker that you want to insert into your clinical decision. So just to summarize this part, is a very simple portable system, very useful because you are going to be able to make 3 different biomarkers at the same time. Of course, technology can be implemented also in the future, but what is, I think, is remarkable is that you can use whole blood. So this is really technology that is going to be able to provide in 10 minutes biomarkers results. Let's go now and try to evaluate which are the clinical acute setting where you really would like to have a to improve your final decision. In this sense, I think it is important to, first of all, to address the importance of sepsis into the emergency room. We know very well from this paper from our group that the sepsis patients with the sepsis are the more at risk to die. Depends how much time they stay in the emergency room. So it is really crucial to take a special effort to reduce the time of patient with the sepsis waiting in the emergency room, because any hour of increase of delay in admission with these patients in the emergency room is linked with increased mortality. So within so many diseases, sepsis patients are really the crucial one. You want to be fast and accurate as much as possible. If you look at the actual service sepsis campaign of 2021, it is very clear that based on that, because sepsis is so crucial, you really want to create a special pathway and take a special care to the patients with the sepsis in the emergency room to reduce the timing of decision making. And I think also it seems very clear that from a clinical point of view, all the score, quick, SOFA, CRS, news are not enough in order to make to speed the final decision. Now let's look which are the biomarkers that are linked with the good possibility to detect the positive bacteria in the culture. Within all the clinical data in red, no one of these is linked with the possibility to immediately detect the positiveness of bacteria in the culture. The only two are Procalcitonin and C-reactive protein. We know very well that C-reactive protein, unfortunately, is very specific, so it's not really mirroring sepsis, while Procalcitonin, that seems from this paper we just published in Biomedicine a couple of weeks ago, is the only one that is going to be able to immediately predict in the culture the presence of sepsis and for the bacteria. And in fact, also guidelines are suggesting procalcitonin and a good biomarker to immediately detect in the emergency room to make sure there is a bacteria there, and so to make a decision for use of antibiotics. So procalcitonin seems between the biomarkers the good one to detect in the case of suspicion of sepsis. And in fact, we have these 4 limits for procalcitonin detection. If a procalcitonin is below 0.5, it seems that there is no really sepsis, probably local infections. And it is really important to understand that below 0.5, the bacteria circulating possibility is very low. While when you go from a range of procalcitonin from 0.5 to 2 or to 2 to 10, this is really high possibility, especially if the value of procalcitonin is between 2 and 10, that the sepsis is there. That means bacteria are into the blood. So there is a really need in this case of the value of procalcitonin between 2 and 5 and 10 to use antibiotics. So there is no doubt that using procalcitonin, you can exclude sepsis if it is below 0.5 or below 0.3, and you can confirm the presence of a sepsis if procalcitonin is between 2 and 10. When if it is even more than 10, it's a really severe sepsis and the patient has a risk to develop septic shock. Nevertheless, all the biomarkers you are using, you really need also to have a little bit concern for the caveats. Which are the caveats that you really want to look when you are using procalcitonin for decision making in the emergency room? First of all, there are neonates that where there is a really very low value of procalcitonin circulating. In the case of patients having major trauma or major surgical intervention or severe burns, procalcitonin really may not always be related to bacterial infection. So these are situations where procalcitonin is not really mirroring infection and sepsis. For instance, if patients are in cardiogenic shock, they can have an increase in procalcitonin that is not linked with infections, and also other situations such as lung cancer or carcinoma of thyroid, where procalcitonin can be elevated while in meantime infection and sepsis is not there. So I think at the end of the day, like all the other biomarkers, procalcitonin is of great utility. You should start at the beginning to check in the risk of sepsis procalcitonin, taking into account some limitation, like all the biomarkers. So definitely, procalcitonin should be considered a good biomarker in order to make a decision to start and monitoring antibiotic treatment in the emergency room. We have on IB10, in the disk that I showed you before technology, the possibility to measure procalcitonin. And this will be available in 10 minutes. And what is important with this system in the point of care in the emergency room using whole blood, you can have a value of procalcitonin between 0.3 microgram liter or 10 microgram liter. What is important again, if the value is below 0.3, you can exclude sepsis. If it is between 0.5 and 10, you can rangely decide that there is a sepsis or septic shock. So it is no doubt that procalcitonin point of care by IB10 will be able to diagnose sepsis, but most important also to give you a severity score of the sepsis. It means that if the procalcitonin is 7, the risk of septic shock is higher, and also the severity of sepsis is higher. So I think this is no doubt that if you have a patient with suspicion of sepsis in the emergency room and you are going to detect by point of care IB10 procalcitonin, including the value of procalcitonin in your clinical judgment, you are going to have in 10 minutes an important information to confirm the sepsis and to start or not antibiotics. Now, the new biomarkers that is going to be available on the IB10, and I will show the results in a short time, is bioadrenomedullin. Like we addressed during last webinar in bioadrenomedullin, but for the people that were not attending that webinar, bioadrenomedullin is a biomarker, it's a key regulator of vascular function. We have two roles for biomarkers into the circulation system. One is responsible for vascular integrity, endothelial function, and the other one is responsible for vasodilatation. So we know very well that in sepsis, the mechanism that's going to link from a septic to septic shock is an increase in vasodilatation, because septic shock is characterized by an important vasodilatation. So to check the vascular function in the sepsis is crucial to immediately detect the presence of septic shock before lactate are increased. So it seems very clear that the role of bioadrenomedullin in mirroring the physiopathological ongoing damage at vascular level is really important. Now, from this study that already we published more than 8 years ago, looking in the emergency room at patients with sepsis, we used the bioadrenomedullin, and we were able, using a cutoff of 70 picogram ml, to distinguish the severity of a patient. So patients coming with the sepsis having a value of greater than 70, the severity of sepsis was greater. Most importantly, this value of greater than 70 was also linked with the need vasopressor use. That means it was patients prone to develop septic shock and then death. So from this first study in clinical practice we performed in our group in Rome, looking for bioadrenomedullin results in patients with sepsis, we definitely were able to confirm that using a cutoff of 70 picogram m, you are able in the emergency room to stratify for severity of sepsis patients, and sepsis patients are going to have septic shock. So it was the first study on one center that was important to be confirmed. The same results, the same cutoff of 70 in the same patient with the sepsis in the emergency room, where the role of a bioadrenomedullin to immediately, before lactate increase, was able to tell the physician this patient is high risk to develop septic shock, was confirmed in these three larger ICU study, Adrenos, Albios, and Frog ICU, where we got exactly the same results in terms of vasopressor need, severity, and mortality in patients with sepsis. So again, the role of bioadrenomedullin in patients with sepsis of the value of 70 picogram ml greater than this value was immediately at arrival in the emergency room able to distinguish between people with the more severe sepsis and prone to develop septic shock with the people that were more stable. I think there is a little bit delay in internet connections. I'm sorry. I'm sorry, there is a little bit delay in into my slide progression. I'm sorry for this. There is some internet issue, I think. Alessandra, can you hear me still? Okay. So now it's next slide. Sorry. So again, using bioadrenomedullin with the same cutoff in this study, we were able to detect immediately patients that with the value of greater than 70 are going to have septic shock, and so you can immediately detect the severity of the patient. So it is no doubt that bioadrenomedullin added to procalcitonin will be of a great utility in the risk stratification of a patients at risk to develop septic shock. I don't know if there is some issue with my internet connections. I don't know if you can properly hear me. Anyway, I think there is a little bit delay in my slide changing. I don't know if Alessandra, can you hear me?
Yes.
I think I have some delay in my slides presentation.
Professor, you are now on the bio-ADM on the IB10 slide.
Alessandra, can you hear me?
Yes, yes, yes.
Okay. But the problem that I have is that I'm not able to share the slides with you. It seems there is any issue in uploading the slides.
No, we see your slides. We see your slides. You
Okay,
are now
now
on the
it's working.
bio-ADM on IB10. Yes.
Sorry. So anyway, what is important that we can have the same technology, IB10 point of care in the emergency room that is able to measure procalcitonin, also to able to measure bioadrenomedullin. So at the end of the day, having this system, you can have in 20 minutes using whole blood, like procalcitonin, IB10, the results of bioadrenomedullin, and immediately detect the severity of a patient's need for vasopressor. You can understand that this is going to be of a great utility into the emergency room daily practice. I think that the issue, okay, it seems a little bit delay in passing from one slide to another. That's no problem. Now we are okay. And this is our results coming from our center in Rome in San Giovanni Hospital, where we are using this technology measuring bioadrenomedullin in patients with the sepsis. And you know very well that comparing the SOFA score as a score of risk for mortality with the bioadrenomedullin, patients coming in the emergency room with the sepsis and having a bioadrenomedullin greater than 70 microgram per deciliter, these people are going to have a very, very low survival rate compared to the patients that have a bioadrenomedullin level below 70. So using this point of care technology, we confirmed the results using bioadrenomedullin in central lab. So it is very clear that this technology is going to reduce the time for decision and to detect the severity of patients in the emergency room with sepsis. Now, one important concept is that another frequent complication of patients with sepsis is the occurrence of acute kidney injury. And in fact, in this study we just published in the multicentric cohort in Asia, where we were able in the emergency room to detect the presence of AKI in all comers, the majority of patients prone to develop AKI were patients with sepsis. So sepsis is really a situation where the patients can have a risk to develop acute kidney injury, which is the issue of making a quite rapid and accurate diagnosis of AKI in the emergency room, that these diagnoses looking at clinical criteria are based on 48 hours change of creatinine, serum creatinine on the value of 0.3 milligram deciliter. So this is a big issue. How can I be really able to detect the ongoing AKI in a patient with sepsis that I have there using creatinine? These are big caveats that is there, because creatinine is not only not able to detect what is going on because it takes 48 hours, but when creatinine is increased, first of all, already 50% of glomeruli are lost. So there is really no time to using creatinine to make appropriate diagnosis of occurrence or not of acute kidney damage in patients with the sepsis. So what we need, since creatinine takes 2 days to increase to mirroring the ongoing acute kidney damage in patients in emergency room, you need a troponin of the kidney like you have a troponin of the heart. So in other words, you need a biomarkers that is able to immediately mirroring the ongoing damage glomerular function at the patient you are looking. You don't want to wait 24 or 48 hours to detect AKI. So there is no doubt that we need a biomarkers like we have high sensitive troponin for acute coronary syndrome to detect the occurrence of AKI. And this biomarker is definitely proencephalin pain kid. this is really a simply extrainable surrogate for measuring GFR in critically ill patients. And as you can see in this iota-Lamate clearance, very good relationship with around the curve of 0.97 of a pen key to detect glomerular filtration. So we have the biomarkers of acute kidney injury that is proencaphalin. And in fact, just talk again about the patient sepsis, it is very clear that if you have a proencaphalin of a value below 80, like in these patients, you can really be able to exclude here or to confirm AKI in patients with the sepsis. So there in this one center in Korea or multicentric study. So like we have bioadrenomedullin cutoff of a 70 to exclude or not septic shock, we have a value of proencaphalin greater or less than 80 to confirm or exclude AKI. And this is also important that in this study and also in FrogICU, you were able to detect the presence of AKI or exclude it or no AKI using proencaphalin, because the mortality is higher in patients AKI detected by proencaphalin, is much less in patients with no AKI with the value of proencaphalin below 80. And what is also important, if you have a normal creatinine but proencaphalin greater than 80, you have ongoing subliminal AKI that is also linked with the mortality. So there are three possibilities using, let's say, online, real-time glomerular filtration rate to detect the different situation, the kidney function in the emergency room in patients with the sepsis. And again, it is very clear that if you are going to measure proencaphalin, you are able also to predict the possibility of a patient to have dialysis, again using these two cutoff. Less than 80 is good, greater than 80 is very bad. So I think it's very important now that you have a real-time biomarker for kidney damage. And in our study, again in San Giovanni, using the same system IB10, it is very clear that it was a link of proencaphalin with the glomerular filtration rate, but also in patients having reduction of diuresis with the sepsis, we are able to show that proencaphalin was elevated. So also using proencaphalin in the emergency room, we can confirm the utility of these biomarkers in detecting AKI. Just go to address the last part of my presentation, the role of another acute disease, very frequent. From some years ago, if you are wasting time in the emergency room and not able to make a diagnosis of acute heart failure as soon as possible, you are going to increase mortality and also hospital length of stay. So like all other acute disease, in the emergency room, emergency physician should be fast and accurate in make appropriate diagnosis to improve patient survival. Sorry, still a little bit delay in the I'm sorry, but there is a little bit delay in the slide progression. I think this is a kind of internet issue, I don't know. Okay, now, of course, also evaluating patients with acute heart failure, you have to make your clinical judgment, and if the patients have a jugular distension of peripheral edema, this third sound, of course, the clinical judgment is important for acute heart failure. And which are the biomarkers that are now of utility in the case of acute heart failure? The recent guidelines 2021, in order to immediately be able to make a fast and accurate diagnosis of acute heart failure, suggesting after the clinical judgment to use natriuretic peptides. And between these, if the value of BNP or NT-proBNP is greater than 100 or 300, you are very good to make a diagnosis. So natriuretic peptides have a great utility in making diagnosis of acute heart failure. I'm sorry. Okay. Now, what is important that from this paper in the Creatinine Network from Christian Mueller in New England Journal of Medicine more than 15 years ago, we were able to demonstrate that also if you are going to be able to immediately detect acute heart failure using BNP, you were able to reduce cost of the management of the patient. So this is not only good for diagnosis, but also to reducing the cost. Okay, like we saw for other biomarkers such as Procalcitonin, also for you have NT-proBNP available on Nexus point of care with the same technology we are using for Procalcitonin or proencephalin or for bioadrenomedullin. And you see very good relationship between NT-proBNP provided by IB10 whole blood disk compared to the laboratory big machine Roche. So there's no doubt that you can count on this NT-proBNP value in the emergency room. Another biomarker that we use every day in the emergency room that is also available in this technology is the dimer. So with the same technology, using at the same time, eventually 3 biomarkers such as high-sensitive troponin, NT-proBNP on D-dimer, and IB10, you can have this short of breath panel that you can make immediately a diagnosis at the bedside of the patients in 10 minutes. Now, let's go to address last part of my talk, looking at the role of a kidney insult during patients, looking at patients with acute heart failure. There is no doubt that worsening renal function in the case of acute heart failure is linked with high mortality. So you really want to check the kidney when you are treating a patient with acute heart failure. And we know very well this definition of cardiorenal syndrome type 1, that means when the heart is not able to pump an adequate blood into the circulation system, the kidney is insulted, and this is making damage into the heart as increase of renal angiotensin system. And every time this occurs, hospitalization is also occurs and the mortality is increased. And from our study with the Boston University, if the patient with in the emergency room come with acute heart failure and has a cardiorenal syndrome type 1, and so with kidney damage, you have an increase on mortality in hospital, 30 days follow-up mortality rehospitalization. So it's a 40% of increase of damage events in patients with acute damage of the kidney in the case of acute heart failure. And between the biomarkers, proencephalin, from this paper published in Journal College of American Cardiology, is very clear that proencephalin is the best predictor of worsening renal function in patients with acute heart failure. Proencephalin you see here, much better than creatinine or natriuretic peptide. So even you have another important biomarker, the same biomarker that was useful for acute kidney injury in septic patients with acute heart failure patients to detect AKI. And we confirmed also in other cardiac emergency this role, again acute heart failure, in a study published in our group with Malmo, the same results, making the value of proencephalin to detect the AKI in patients with acute heart failure and then increasing in mortality, and the same in patients in this red zone having cardiogenic shock where the kidney was insulted, proencephalin was able to predict mortality. So also in the case of acute damage of the heart, proencephalin is able to support the risk stratification of the patients. In last 5 minutes of my presentation, I am sorry if I take a little bit more because some slight issue, I will present a case report where I show you how can we really take benefit using IB10 point of care in the emergency room in the patients with acute disease. These are patients over the 70 years old that came with a situation of congestive heart failure, oliguria, that was not responding to increased dose of furosemide at home. So it was already a very clear cardiovascular disease story with the coronary artery disease, PTCI, atrial fibrillation, already chronic kidney failure, but he also had a recent intervention for aortic valve replacement. So it was a very severe patient coming with acute heart failure. Acute heart failure was confirmed with a chest X-ray. You see the enlargement of the heart, presence of a lung congestion, also confirmed on point of care ultrasound with the B line, but also with the vena cava dilatation, with a very congestive situation, with a very critical hemodynamic situation, and also with the pacemaker function that it was really in bad critical scenario. Now, the question for everybody is which kind of biomarkers you want to test. For sure, you want to test glycemia. For sure, you want to test creatinine or procalcitonin or probably galactin-3 or ST2 or NGAR or BNP. I think what is important and what in this kind of patient, you send the blood lab to laboratory to check for glycemia, renal function, electrolytes, high-sensitive troponin, and hemoglobin. And these results can wait a little bit, right? You can even wait for results in 1 hour because are important, but not really tremendously impacting your decision. While if you have a point of care in the patients like this, you want immediately to know how much is NT-proBNP to confirm the diagnosis. You want to see procalcitonin to see if there is any pneumonia or bacterial infection that is relapsing heart failure, and also you want to check the kidney. So I really suggest to have a kind of this setting of laboratory testing, these three immediately, and this one you can wait a little bit, but you still want, right? So let's see the result in these patients. Of course, it was some anemia because it was surgery. You know, his patients has already a story of chronic kidney disease. So if you have this creatinine 2.3 and the sodium also low because of diuretic, you don't know if something is even going worsening in this patient. And in fact, procalcitonin was negative. This means that the patients obtained by IB10 testing was having no infections. So the reason of relapse of acute heart failure was no infection. So there was no need for using antibiotic. And this is very important because you don't want to use antibiotic in a patient with acute heart failure because the mortality is going to be increased. On the other side, NT-proBNP from IB10 whole blood in 10 minutes was highly elevated, confirming the presence of acute heart failure. But I think the most relevant results were coming from proencephaly, meaning there was acute damage of the kidney on chronic damage, so of the chronic kidney dysfunction. So this means of a very risky patient. And I think is a really clear situation when you can confirm the presence of cardiorenal syndrome and make a different decision making for the patients, I don't know, increasing furosemide or muzolimine or making for dialysis or something else. So the next future using IB10 is telemedicine, because I think here now we are increasing the possibility to send from a nurse's house to the patient some clinical evaluation plus biomarkers, and the physician here can ask you, please give me the results or I don't know, many proencephaly to make a better decision. So I think it's another area where I see the value of this technology with the telemedicine support. And this is the reason of why the global trends of point of care testing is increasing worldwide. So it means that people are really looking at to have as much as possible this device in the emergency room. And this is the recent paper where we were able to increase in India, 1,300,000,000 inhabitants, the role of this point of care system into the emergency rooms. There is also a further possibility to connect this testing from IB10 thanks to a wireless router to central lab if you want to really validate your data. So there is also possibility to connect this data with the central lab. But at the end of the day, I was just to remark, closing my talk, that you really want to look carefully at the role of the number of biomarkers, because you really want to insert your number of the biomarkers obtained by point of care into clinical decision. But it is important that you can do everything at the same time. You are visiting the patient, you see the biomarkers, and you see how it's going to fit in your clinical decision. Because at the end of the day, biomarkers will make bad doctor worse and the good doctor better. So I mean, still is a conjunction between biomarkers and clinical judgment, and I think it is really crucial to make this lesson. So what do we have at the end of these three webinars? We have ability of a new biomarkers such as Bioadrenomedullin and proencephalin, able to give you important information in severity in patients with the sepsis or kidney damage or cardiorenal syndrome. You have also old biomarkers such as NT-proBNP or Procalcitonin on D-dimer that still are crucial in the emergency room. You want immediately these biomarkers. And the good news that the IB10 technology using whole blood is going to give you in 10 minutes all these results. Thank you very much. I apologize. It was a little bit problem in slides. presentation, but I'm open now to answer all the questions that are coming. Thank you.
Dear professors, thank you very much for your presentation. Despite of some delay and some connection problems, it was a very interesting presentation, as usual, with a clear story, and I'm happy to open the Q&A session now. We already have some questions from the participants, and I will be happy to read them out to you.
Okay.
So the first question, let's see, maybe I read out the questions not in the right order, but so the first one, how can I use both PCT and bio-ADM to stratify septic patients? And can I run both tests at the same time on IB10?
Okay, this is a very important question. First of all, I really suggest to do both procalcitonin and bioadrenomedullin in all cases of septic patients in the emergency room. Because the use of multi-markers in the clinical acute scenario is that are going to mirroring two different physiopathological ongoing mechanisms. So you need procalcitonin because you need a confirmation of a diagnosis, right? So you need procalcitonin to be able, like guidelines suggest, to confirm diagnosis and immediately use antibiotics. So a procalcitonin is able to mirroring the presence of a bacteria into the blood and also to suggest to use immediate antibiotic. And this is the reason why I really recommend to use procalcitonin in all patients in the emergency room. Not only that, but if you start antibiotic, you also want to continue monitoring procalcitonin in the days coming after to see if the procalcitonin is going down, to check if the antibiotic is working well or not. So procalcitonin is really important in patients with sepsis because it's mirroring the presence of bacteria and then the need for antibiotic. And also, eventually, if it's going down, antibiotic stop. On the other hand, bioadrenomedullin is more a risk stratification biomarker, right? Not only you want to make a diagnosis of sepsis, you want to understand how much is the possibility that this patient is going to die or to develop septic shock. And bioadrenomedullin is mirroring exactly this. So the two biomarkers are complementary. Bioadrenomedullin is going to tell you these patients, although he has lactate not elevated, is going to have a septic shock very soon, in 24 hours. So this is really a kind of a complementary activity between procalcitonin and bioadrenomedullin, mirroring different ongoing physiopathological mechanisms in the sepsis, and so there is a reason to use together. Now, coming on the second specific good question, could I use both? At the moment, the system is not able to provide the two biomarkers at the same time, but they are working SphingoTec to provide this possibility as soon as possible. So the device is built for giving the two biomarkers in the same time. At the moment, you can do one by one, but if each biomarker takes 10-15 minutes, you still have 30 minutes. That's much better than having procalcitonin or bioadrenomedullin from the central lab that's coming in 2-3 hours. So just to properly address the second question, shortly, it will be available to have a bioadrenomedullin procalcitonin with the same whole blood drop, but at the moment you can have you can measure the two different discs, one for procalcitonin and one bioadrenomedullin. Okay.
Thank you very much for such a full answer. From my side, a small remark, we do have some panels where 3 biomarkers can be measured at the same time. This is a standard of care biomarkers like the shortness of breath panel for the acute heart failure. So the next question, what do you think could be the possible limitations of point of care in the emergency department?
Okay, of course, the limitation should be if the device is not going to give you appropriate and validated results. But like I show you during my presentation, the biomarkers that are going to be presented and are using are already validated with the platform of the Roche. So I think actually we can trust for the biomarkers for IB10 because they have been validated with the central lab machine. So this is the risk that, right, that you have going to have a point of care that is not really going to reflect the value from the central lab. Using IB10, I show you a very good relationship between the IB10 biomarkers data and the central lab by Roche. So there is no doubt that there is not the case. anyway, if you sometimes you are a little bit concerned about the value that you are receiving, you can connect by wireless to the central lab the results and do in real time, and so in real time you can have the control. So anyway, from IB10 we have not this problem because they have been validated for the central lab Roche system, all the biomarkers that are using. The point of care generally can have another issue that is a little bit underestimated, is hemolysis, right? Because we know that hemolysis is a little bit present in a short percentage of a patient, and this the system that is a little bit affected point of care, but is even more important in other analyses such as blood gas analysis that are using point of care with a little bit hemolysis. And this is something we should work together. But at the moment, I think we can trust this point of care, at least with IB10, because it's validated with the central lab.
Thank you, Professor. Next question, do you use troponin from the IB10?
Oh, this is a very good question. To be honest, since this is not high-sensitive troponin, I don't use the IB10 for measuring troponin I because it's not high-sensitive. So I really would like in the future to have high-sensitive troponin IB10, because we know very well that the rest of the guidelines really highly recommend to use high-sensitive troponin and not regular troponin. This is a good troponin, but it's not high-sensitive. So if there is a very remote area patients, I still can use troponin from IB10. But generally, I don't really recommend to you to trust too much the not high-sensitive troponin. So just to conclude, I don't use IB10 in my hospital with troponin because it's not high-sensitive, and I can have high-sensitive troponin from the central lab in 1 hour. But I cannot exclude that in very remote area, in the telemedicine program, like I show you, if you have a patient that where you have no central lab, have troponin, even though high sensitive, is better than have not. Is that clear, Alessandra?
It's clear. Thank you for your answer. And may I ask the next question? So could we predict the need of ECMO in patient coming to emergency department by using any of Nexus biomarkers?
Oh, definitely. I think this is a very good question. I think bioadrenomedullin is a perfect candidate for predict the need for ECMO. This is something that we should, and also not only that, coupled with the proencephalin. So if I have a very severe patient having a very high level of bioadrenomedullin, even also some increase in lactate. So there is a additive value of using lactate and bioadrenomedullin in the emergency room, because if the patient is coming in with lactate already more than, let's say, 3, and the bioadrenomedullin more than 120, and having proencephalin, PenKid, greater than 150, definitely is a very acute risk patient. I can really think that this patient can benefit in next days of ECMO. So I think there is a possibility in the future. We have not specific data on this question, but I think in the future, using these 3 biomarkers, bioadrenomedullin, lactate, and proencephalin, you can select a patient that from the beginning can benefit of ECMO. We know that ECMO is going to be increasing the utilization a lot after the COVID. So the more we are familiar with the technology, the more we have to look at which biomarker can predict the utilization of the ECMO.
Thank you very much for your answer. And Dimitra, thank you for your very interesting question. So do we have more questions here? Yeah, in the previous webinars and now we always talked about the role of the biomarkers in the emergency department. We have a question, Professor, whether you think IB10 and its portfolio, so different biomarkers, can fit also into the ICU.
Oh, this is absolutely good. No, we use in ICU point of care blood gas analysis, right, every day. And I think we should consider IB10 in ICU like we do for blood gas analysis. All ICU, they have a point of care blood gas analysis because they need to monitoring the patients with the blood gas analysis, right? So they need to every day to look at pH, to PO2, PCO2, lactate. So the same thing is for IB10. If I have a patient that in the emergency room have a value of, I don't know, for instance, procalcitonin greater than 5, And so with the high risk to have a sepsis, and then I start antibiotics, I see a room in the ICU to monitoring procalcitonin for the escalation of antibiotic treatment. So I see that it would be good to maintain the same technology to monitoring procalcitonin. And the same for IB10 and the same for proencephaly. So definitely, if you start with the IB10 in the emergency room, I see the value to continue the same technology in ICU to monitoring the patients.
Thank you very much for your answer. I do not see any other questions from the participants. I have a question from myself. You have mentioned the telemedicine in your presentation and in your answers. Do you think you could tell a little bit more about this telemedicine project you did in the Italian hospitals?
Yeah, I think this is really the future. You know very well that after the COVID, we are going to increase the telemedicine use because there is a lot of patients that can benefit at home to be monitored and send the data to the nurses station and then to the hospital. Just let me tell you what we did with COVID. You know, in COVID, there are two clinical situations that can deteriorate if patient is stable at home. During the control of every day, sending the data from the home of the patients with a smartphone, we are collecting clinical data. Then, if the patient was going to have some, let's say, deterioration of clinical condition from COVID, we were sending at home a doctor with the IB10 machine. And you know that also it is important in this patient to look at the D-dimer for prevention of thromboembolism because COVID was also linked with the risk of a pulmonary embolism. So we were measuring D-dimer, procalcitonin for the need of antibiotic or not, and sometimes bioadrenomedullin to decide to send the patients at home. So in the future, this approach to have in the small peripheral hospital, but even into the house, a team that is going to measure this biomarker, sending to the nurses station or to the hospital, this research should be of a great utility to reduce the inappropriate emergency room overcrowding and even to detect which patients can benefit to be immediately transferred to the hospital.
Thank you. That sounds very interesting, the project in telemedicine. And we have more questions coming in from the attendees. From Peter from Sweden, the question is the following. Do you see the future for a use of IB10 in ambulance?
This is also very important. Absolutely, yes. Because I think that for sure a patient is very critical, for sure with acute heart failure, right? And you do in the meantime, and the patient is coming in the emergency room already NT-proBNP and also proencephaline, and to detect there is already some renal damage, you can tell the emergency physician, look, this patient has some kidney damage, so use more diuretic, less fluid. So it is important information, and I think really should be something that should be used in the emergency room. And the same for the septic patient, right? At least for detect procalcitonin. I really would like to know how much the procalcitonin is going to be in patient with the sepsis and bioadrenomedullin. So the more is advanced in terms of timing, saving the results of biomarkers, the more useful for patients and for doctor who works in the emergency room.
Thank you. And one more question. Does IB10 analyzer need any maintenance?
Oh, absolutely not so much, because at the end of the day, you just make some calibration. But you see, since it is really using whole blood, you really don't need special attention. You just need to change the disc. Of course, sometimes you need to check the quality, but it is something that's not really require too much effort. So it's very simple.
Yeah, thank you very much, Professor. If there are no more questions from our participants, I don't see that anyone is typing. I would like to close this webinar and thank Professor Di Somma for his very interesting presentation and the talk. It was a great look for us into the use of point-of-care diagnostics and biomarkers in the emergency department. I would also like to thank all the attendees for their attention and their participation and very good questions. So thank you very much and have a good day, everybody.
Thank you very much. Thank you, everybody. Sorry again for the problem in the slides. Bye. Ciao.